In this section, we're going to talk about how the cardiovascular system responds to dynamic exercise in terms of blood pressure. Remember that dynamic exercise is cardiovascular exercise, also known as aerobic exercise. So things like walking, swimming, running, cycling, gardening, etc. That's dynamic exercise. On the y-axis, we have blood pressure in millimeters of mercury. And on the x-axis, we have maximal oxygen uptake as a percent. So this gives us the exercise intensity, or how hard we're working. At rest, a good systolic blood pressure is about 120 millimeters of mercury. At rest, a good diastolic blood pressure is about 80 millimeters of mercury. We're going to compare arm work versus leg work. So if I'm doing an arm ergometer versus a leg ergometer. With arm work, systolic blood pressure goes from 125 to about 200 millimeters of mercury as we increase exercise intensity from 25 to 75% of max VO2. The diastolic blood pressure goes from about 90 millimeters of mercury to almost 100 millimeters of mercury. It doesn't change all that much. If we compare systolic blood pressures in arm work versus that of leg work, here's what happens. One is that we can go all the way to 100% of max VO2, whereas with arm work, we were not able to achieve 100% max VO2. The second thing is that blood pressures go from, let's say, about 115 millimeters of mercury to about 150 millimeters of mercury. So blood pressures are far less in leg work compared with arm work as far as systolic blood pressures are concerned. When we look at the diastolic blood pressures, they barely change in leg work. They're going from, let's say, 70 millimeters of mercury all the way to 80 millimeters of mercury. There isn't much change at all. So how do we explain all of this? How is leg work different from arm work? The first thing being here is that the harder we work, the more vasodilation and therefore the more forceful the heart contractions will be. So arm work is much harder, much more difficult than leg work. So systolic blood pressure and of course diastolic blood pressure is going to be higher in that type of work. So why is this happening? In dynamic exercise involving leg work, there's a much larger vascular bed for vasodilation. So think about this. The arterioles are vasodilating in response to the amount of work we're doing and the demand for blood flow. And as you recall, if I vasodilate, I'm going to lower TPR. Well, if there's lower TPR, that means I have a lower afterload, which means that the heart can eject more blood out of the heart without having to build up a lot of pressure. And that's exactly what you're seeing here. In arm work, there's a much smaller vascular bed for vasodilation. So the resistance is going to be higher. That TPR is going to be higher. So therefore, if you have higher TPR, you're not going to be able to eject more blood out of the heart compared with leg work. This is a really important consideration when we're talking about patients with cardiovascular disease who are in a cardiac rehab program. What modality are you going to choose? Are you going to choose the arm ergometer or the cycle ergometry or the treadmill? According to these blood pressure responses, especially when they're in the earlier phase of cardiac rehab, it would behoove that person to start with something that involves leg work if they can. You're not always going to have patients that can start off with leg ergometry. And the simple reason being because of how they respond in terms of blood pressure. So if we respond with a higher TPR, that could be problematic for somebody with underlying CAD. Now let's look at the blood pressure responses with static exercise or resistance exercise or weight training. On the y-axis we have blood pressure in millimeters of mercury, and on the x-axis we have various conditions. We have a resting condition, then we have a one-arm 100% maximal voluntary contraction. So this is a one-arm dumbbell curl with a really heavy weight that can only be accomplished with one rep. We have a one-leg 100% maximum voluntary contraction using the sled that you see pictured in the upper right-hand corner of your screen. So this is using a heavy amount of weight where only one repetition can be completed. And then we are using that same sled with both of our legs and doing this at 90% of maximum voluntary contraction to failure. So we're doing multiple reps. And then we're doing two legs, 100% maximum voluntary contraction on this same sled, but only doing one rep. How are we going to respond? At rest, again, 120 over 80 millimeters of mercury is a good blood pressure. And these are box plots, so the top of the box represents the systolic blood pressure, and the bottom of the box represents the diastolic blood pressure. A one-arm 100 MVC, you might get something like this. So obviously we're going to get an increase in blood pressure. A one-leg 100% MVC, a little bit higher blood pressure. Two legs 90% MVC to failure, and then two legs 100% MVC to failure. Why do we have these differences? Is it the amount of muscle mass that causes these changes? Well, not really. It's only somewhat related to muscle mass. Take a look at the one leg 100% versus the two legs 100% MVC. There isn't really much of a difference there in terms of the blood pressure response. Take a look at the blood pressure responses for the one arm versus the one leg versus the two legs. If the amount of muscle mass was responsible for the changes in blood pressure, we'd see more dramatic differences here. And we're just not seeing that, especially when you look at the one leg versus the two legs. There's a significantly more amount of muscle mass being utilized with two legs versus one leg. So the amount of muscle mass is only somewhat related to the blood pressure response. So what's responsible? Well, there are three mechanisms responsible for this increase in blood pressure. One explanation is that of the Valsalva maneuver. This is where we hold our breath against a closed glottis. So we, during static exercise, we hold our breath, and that drives up blood pressure because we've increased the intrathoracic pressure. So that means that TPR is going to increase, and of course that increases afterload, and that increases the blood pressure. So in these graphs, if any of the study participants perform the Valsalva maneuver, that's going to create a higher blood pressure response. The second mechanism in place is that of the contracting muscles are causing physical mechanical closure of blood vessels. So anything greater than a 60% MVC or a 60% maximal voluntary contraction, that's going to cause the blood vessels to collapse. When you do that, that's going to create a higher TPR. So in these graphs, the amount of muscle mass we said is partly related to the increase in blood pressure, and that's where some of this is coming from because of the mechanical closure of these blood vessels. Again, the contraction has to be at least 60% of MVC to see mechanical closure of these blood vessels. That then is going to drive the increases in blood pressure. The Pressor response, or the Pressor reflex, is where we're going to see the most in terms of response in blood pressure. This is where sensors in blood vessels are telling the central nervous system that blood flow has been cut off. So the central command is essentially going to respond by forcing more blood into that area. It does that by increasing blood pressure. When we do that, that of course is going to drive up blood pressure and therefore TPR and increase afterload. So the responses that we see with resistance exercise or static type of exercise comes from the fact that we are putting in more effort, which means that we're going to get a greater response. And that is evidenced by the two legs 90% MVC to failure. So we're doing heavy repetitive lifts that really stimulate this Pressor response to kick in. So in summary, it's the Pressor response or the Pressor reflex that's really responsible for these tremendous increases in blood pressure, more so than the mechanical closure of blood vessels and the Valsalva maneuver. So how does dynamic and static exercise compare? On the y-axis, we have blood pressure in millimeters of mercury, and on the x-axis, we have rest, aerobic exercise or dynamic work. We have a two-arm curl with a heavy load. Then we have a two-leg press with a heavy load. At rest, of course, 120 over 80, good blood pressure. During dynamic exercise, our blood pressure with maximal exercise might reach 175 millimeters of mercury in terms of the systolic, and maybe about 80 millimeters of mercury for the diastolic. If we perform a two-arm curl with heavy load, blood pressures are increased. Same thing goes for a two-leg press with a heavy load. So where are we getting the most increase in blood pressure from? We're seeing the highest blood pressures come from static work versus dynamic exercise. The kinds of pressures that we see during static exercise are enough to pop blood vessels, particularly in the eyes. At competitions, you may notice that some of the competitors will have bloodshot eyes, and it's because of all the high vascular forces that they're contending with. If you throw in the Valsalva maneuver, in addition to that, you're going to have a nice situation that will lead to broken blood vessels. So to summarize our blood pressure responses during exercise, static heavy resistance exercise is going to lead to a very large increase in both systolic and diastolic blood pressures. This is mainly due to the Pressor response, but the mechanical closure of blood vessels as well as the Valsalva maneuver also contribute. With rhythmic dynamic exercise, particularly if we're using leg muscles, we have a very large muscle mass, so there's a much larger area for vasodilation. As we increase the exercise intensity, the systolic blood pressure is also going to increase. The diastolic blood pressure remains relatively steady as the exercise intensity increases because of that large vascular bed for arteriolar vasodilation. A smaller muscle mass, on the other hand, is going to give us a much higher blood pressure compared with the larger muscle mass. So with dynamic exercise, we're going to get an increase in venous return. There'll be a linear increase in heart rate and cardiac output. It's important to note that stroke volume actually reaches its max at about 50% of VO2 max. It's important to remember that we vasoconstrict all non-essential areas, so we divert more of that blood to the skeletal muscle. And of course, we're going to have an increase in blood flow to skeletal muscle that closely mimics the pattern of motor unit recruitment. In the next 4 diagrams, we're going to look at 3 populations. One population with mitral stenosis, so remember that's the mitral valve and a narrowing of that valve, which means that we can't pump as much blood through that valve. We're going to look at a normally active individual, and then we'll look at the elite athlete. In this figure, we're looking at heart rate on the y-axis, and on the x-axis, we have oxygen uptake in liters per minute. So remember, this is an indicator of how hard we're working. This is the intensity level. So in this diagram, what do we see? We see the fact that with elite athletes compared with normally active and mitral stenotic patients, that heart rate doesn't increase at the same rate. So an elite athlete is going to be able to exercise at a higher intensity level, but at a lower heart rate compared with normally active or mitral stenotic patients. In this diagram, we have stroke volume on the y-axis in milliliters, and again, exercise intensity as oxygen uptake in liters per minute on the x-axis. Stroke volume is going to be the highest in elite athletes. The main adaptation to regular exercise in elite athletes is going to be in terms of improving stroke volume. And that comes from the persistent and repeated increases in preload that we see with exercise training. In this diagram, we have cardiac output on the y-axis and again exercise intensity on the x-axis. The elite athlete is going to be able to increase cardiac output far more than somebody who's normally active or somebody who has mitral stenosis. In this diagram, the y-axis is the AVO2 difference. That is the arterial to venous oxygen difference. So this is the difference in oxygen between the arterial side versus the venous side of things. Obviously, skeletal muscle is extracting oxygen, thereby lowering the amount of oxygen in that blood that's getting passed along to the veins. So the AVO2 difference just represents the difference between the arterial side of things versus the venous side of things. In conditioned athletes, you can see that the AVO2 difference will actually improve with exercise training. Athletes are better able to extract more oxygen out of the bloodstream and utilize that oxygen more efficiently. Let's look a little bit more closely at cardiac output and exercise performance. These 3 panels show us on the y-axis cardiac output in liters per minute, leg blood flow in liters per minute, and then oxygen consumption in liters per minute. And on the x-axis for each of these panels, we have exercise time in minutes. The panels are also divided between just leg work on the left-hand side versus leg work plus arm work on the right-hand side. That's what that dashed line represents. As we begin to exercise, we expect cardiac output to increase with leg work, and that's exactly what happens. When we add arm work, we see that cardiac output increases a little bit more. What happens to leg blood flow? Leg blood flow, obviously with just leg work, increases, but look what happens when we add arm work. We actually compromise our leg blood flow by adding the arm work. Think about this. We are trying to share that cardiac output now between our arms and our legs. So although cardiac output increases, it comes at the sacrifice of diverting some of that blood flow away from the leg muscles to the arm muscles when we are doing both arm and leg work. Can you think of an activity that utilizes both arm and leg work? Cross-country skiing is a great example of this. Now, what about oxygen consumption? Oxygen consumption with leg work will obviously increase. We add the arm work and we're going to get a little more oxygen consumed because there's just overall more muscle mass that's requiring oxygen for oxidative metabolism. Let's take a look at the training adaptation differences between volume and pressure overloads. With a volume overload, what we're really talking about here is rhythmic dynamic exercise. There's going to be an increase in the compliance, that is the stretch of the heart. Don't forget that Frank Starling law of the heart. There's going to be a small increase in the left ventricular wall thickness because we're focusing on the volume increase and not necessarily the myocardial thickness. There's going to be an increase in myosin ATPase activity. And as you recall from the metabolism lecture, ATPase is the enzyme that's responsible for breaking apart ATP. There's going to be increased capillary density so we can deliver more blood flow to the working muscle, as well as an increase in the oxidative potential. So with rhythmic dynamic exercise, what we're focusing in on is volume overload. That is increasing preload. Because of that, we're going to focus on placing a stretch on the heart rather than having to contend with high vascular forces. And with pressure overload, we're really talking about static exercise or resistance type of exercise. The heart is going to get stronger. There's going to be an increase in left ventricular wall thickness, so we get left ventricular hypertrophy. The heart does get stronger, but there's very little increase in the volume of the heart. This volume overload versus pressure overload is what is known as the Morganroth hypothesis. You'll often hear people say that aerobic exercise or dynamic work, running, cycling, biking, swimming, etc., makes the heart stronger. Is that really true? Is that what's really happening? Well, just a little bit, because this type of work, we're focusing in on making the heart more voluminous. So we're trying to increase preload. And very little of dynamic work is actually going to force any increases in afterload, right? Because we saw how the vascular bed just opens up and lowers the TPR. So that stimulus for the TPR to force an increase in the hypertrophy of the left myocardial wall simply is just not there. Whereas static work, weight training, right? Resistance training, that type of work is going to increase afterload, and that is going to force the left ventricle to thicken. It's going to have muscular hypertrophy from all of those pressures and all of those forces that it has to contend with. So it has to adapt to be able to force blood out of the heart. So the next time that somebody says aerobic exercise makes your heart stronger, you can now tell them, well, not really. You get a little bit of an increase, but that increase really is going to be in the form of a more voluminous heart. You may be asking yourself the question, if strength training increases TPR so much, isn't that bad for me? Isn't that increasing the afterload of the heart? Isn't that setting me up for a prolonged isovolumetric contraction phase so the heart is not getting as much oxygen as it needs? Well, the answer to that question is no, it's not going to cause any adverse side effects. So your heart will get stronger with resistance training, but there isn't going to be an increase in the overall volume of the heart. These are good changes that happen with weight training compared with somebody who has hypertension. Somebody who has hypertension, beat to beat, is going to have chronically high TPR, which means that from beat to beat, there is going to be a much higher afterload. What happens in hypertensive patients is that the heart becomes stiffer because there's more connective tissue and more fat around the heart. There's going to be a decrease in the size of the left ventricular chamber, which means that there's less blood that can be held in that ventricle, which means that there's less blood that's going to be pumped out. In fact, myosin ATPase activity is going to decrease in this situation, which means I can't break apart ATP as quickly, which means that I can't contract as forcefully or as fast as I need to in order to overcome TPR. So there is a large increase in left ventricular wall thickness. These are all bad adaptations. Acutely with static exercise or resistance training, that's okay because that's not chronic. That's happening in an isolated period of time, which then you get some relaxation, and you're not going to get any of the adverse consequences if you're dealing with chronic hypertension from beat to beat. So in other words, the heart is chronically overloaded with hypertension versus somebody who just weight trains 2, 3, 4 days a week. It's an isolated event. So let's play around with some numbers here. So at rest, the EDV might be 110 milliliters. The ESV might be 40. That gives us a stroke volume of 70 mLs. Under maximal exercise in somebody who's not trained, that EDV might go up to 140 and ESV might go down to 20. So we've squeezed out more stroke volume, about 120 milliliters worth. Someone who's resistance trained will increase their EDV a little bit beyond maximal aerobic exercise, maybe 145 mLs, but their end systolic volume is down to 5 mLs. What happened here? Well, they were able to more forcefully push that blood out into circulation, so their stroke volume's a little bit higher, 140 mLs. When you compare that with somebody who's been endurance trained at maximal exercise, their EDV is 190 milliliters versus their ESV down to about 10, giving us a stroke volume of a whopping 180 milliliters. That's a huge amount. So these are good numbers to kind of play around with in your head to help you describe these training adaptations between static and dynamic work. These adaptations that we've been talking about are central adaptations. That is, they are centrally located within the heart. But there are also peripheral adaptations that occur. As we saw earlier, the AVO2 difference is different among athletes versus a disease state versus someone who's normally active. And this can increase by about 10 to 15% in somebody who trains regularly. There's also going to be increased capillary density. That's going to allow more blood to be delivered to the skeletal muscle, as well as an increase in oxidative enzymes so that we can ramp up metabolism a bit more. This brings us to the discussion of function versus performance. If we're talking about function, that is the cardiovascular function, that's going to be related to VO2 max and the associated changes in cardiac output and therefore blood flow. If we talk about performance, we're talking about the ability to perform submaximal work. We're talking about adaptations that happen in the periphery. This is related to all of the improvements we get in oxidative phosphorylation in the periphery. Now it's interesting because in this comparison of function versus performance, they both work together. When it comes to VO2 max, just because you have a high VO2 max, that's not necessarily indicative of good performance. In order to be a successful athlete, you have to have both the function and the performance in place. So you have to have the central adaptations and the peripheral adaptations in order to be successful. So in other words, you can't have one without the other. You can't have function without performance. You can't have performance without function. It's interesting to compare VO2 max among individuals with varying levels of activity. Sometimes you might run into a situation where somebody has a really high VO2 max, but they're completely sedentary. They wouldn't be able to go out and run a marathon even though they have the machinery in place genetically that would give them that ability. So the point being here is that just because you have a high VO2 max doesn't mean you're going to be a great marathon runner, for example. So our understanding of this functional capacity in VO2 max versus performance, that is, all of the peripheral adaptations, is really important because these peripheral adaptations are going to be related more to enzymatic activity, mitochondrial density, and the ability to extract oxygen from the blood that's being supplied to the skeletal muscle. So VO2 max and all of the peripheral adaptations have to be there in order to be successful. So let me give you an example of this function versus performance. If I train for 3 months with endurance type of training, I can increase my VO2 max by, let's say, about 19%. However, my submaximal work performance will increase by 300%. Why is this? To understand this, let's take a look at these two figures here. So on the y-axis on the upper panel, we have oxygen uptake, cardiac output, the AVO2 difference for systemic circulation. Then in leg circulation, we have total blood flow, the AVO2 difference, capillary density, and oxidative enzyme. So with 2 to 3 months of endurance type of training, what are we going to see? We're going to see major differences, particularly in the oxidative enzymes as well as the capillary density within the leg. So function-wise, we're not going to see as great of an adaptation occur. That takes years. So on the bottom panel, what we see is oxygen uptake, cardiac output, and the AVO2 difference for systemic circulation, and then in leg circulation, we see the AVO2 difference, capillary density, and oxidative enzyme. So 2 to 3 years of training with cardiovascular type of work, with dynamic work, we're seeing a tremendous increase in not only the function, so our cardiac function increases, our VO2 max is going to increase, but we're also seeing a tremendous adaptation in performance. So our submaximal performance will increase as well. So these slides show us function versus performance. That is central adaptation versus peripheral adaptations. So in the short term, in 2 to 3 months, we're going to have a lot of peripheral adaptations that are going to help us increase our submaximal performance. Whereas if we really want to improve function, we have to be at it for 2 to 3 years in order to get those central adaptations. Think about this from the Olympics standpoint. If I want to be in the Olympics 4 years from now, I need to start training now, not 1 year before. And the main reason is because I need to have these central adaptations in place, that functional performance, as well as the peripheral adaptations. And that takes time. As a healthcare practitioner, you might run into a situation where a client or patient tells you, why should I bother with exercise when I have anti-hypertensive medications that are going to help me lower my blood pressure? Why should I do all that work? Well, this next slide is going to show you exactly why it's imperative for everyone to exercise. On the y-axis here, we have two panels. We have blood pressure on the top panel, and on the bottom panel, we have the T to R ratio. This stands for the left ventricular wall thickness to cavity ratio. So this is basically telling us how much volume the left ventricle can hold. That's what that ratio is telling us. On the x-axis, we have a group that only exercised with no medications from 0 months to a year. Then we have another group, the drug-only group, that only took prescription antihypertensive medications, again going from 0 months to a year. Let's see what happens. In the exercise-only group, what we see is that blood pressure really didn't change that much. So systolic blood pressure went from, let's say, 145 millimeters of mercury to 140 millimeters of mercury. Not a significant drop. Same thing with the diastolic blood pressure. In the group that only took antihypertensive medications, of course, there was a significant drop in blood pressure. We've gone from 145 millimeters of mercury all the way down to about 120 millimeters of mercury or so for their systolic blood pressure. So it appears that maybe the client or patient is correct. Why should I do all that work when I take my antihypertensive medications and I get a major drop in blood pressure? Well, here's where the difference is, and that is in the T to R ratio. And remember, this is the chamber size of the left ventricle. What happens here? With the exercise-only group, what we see is that the T to R ratio actually decreases. That translates into a much more voluminous heart. So with dynamic exercise, we're getting a more voluminous heart. We've already seen that. We know that with dynamic exercise, that increases the preload on the heart. That's a volume overload. With the drug-only group, look what happens. The T to R ratio barely changes, meaning that the chamber size, that left ventricle, did not change size. While we were able to lower blood pressure in this population, it did nothing to change the volume or the chamber size of that person's heart. So the take-home message is this: you may not be able to lower blood pressure in a population that's hypertensive, but they're going to have a healthier heart because that heart has a much larger volume or capacity to hold blood, which means that they can pump more blood out to circulation. In summary, the cardiovascular system is geared towards supplying the metabolic needs of tissues. So when skeletal muscles have a high demand for oxygen, the cardiovascular system is going to try to match that demand by increasing the cardiac output to match that demand for oxygen with an equal supply of oxygen. It's important to remember that those central adaptations that increase VO2 max are going to come about mostly because of an increase in stroke volume. Hand in hand with the central adaptations are the peripheral adaptations that are important, that typically happen much sooner with training compared with the functional improvements. With that said, we do get some central adaptations that take 2 to 3 months. However, to really maximize a person's potential, we are going to look at training for 2 to 3 years. Chronic exercise will lead to these central adaptations, which will allow VO2 max to increase because of a lot of the structural changes that happen within the heart, mainly that the heart becomes more voluminous from that increase in preload. So the principal goal of conditioning is to volume overload the heart. A volume overload is going to be better than a pressure overload when it comes to improving functional performance. Just remember that the greater the muscle mass, the greater the adaptation. So doing leg work is going to give us far greater adaptations compared with arm work. Static or heavy resistance exercise is going to lead to some very large increases in blood pressure. This increases afterload, and of course that comes from an increase in TPR. We should also understand that increases in blood pressure are related to muscle mass, particularly with dynamic exercise compared with static exercise.